All right, and welcome everybody to our September coffee chat. Oh my gosh, I can't believe it's September. I also feel like I say that every month. Welcome, welcome. Like I said, we are recording to add to our YouTube channel, and we do have live transcript available. If you'd like to turn that on, there's at the bottom of your screen, your Zoom screen, there's a button that says CC, and that'll turn on the live transcripts for you. These are our agreements we like to go through before each meeting. We want this to be a safe space for everybody to be able to share and listen and take the space they need, and also make space for others, again, to create that safe space. And welcome. We can go around and do introductions. Let us know your name, where you're calling in from, and as a child, what did you want to be when you grow up? So I can go ahead and start. My name is Laura Jackson. I'm the Director of Community at PFCC Partners. I am calling in from Eugene, Oregon. And as a child, I wanted to be a doctor. When I grew up, I spent so much time in and out of hospitals that I thought, that's what I want to do. But here I am kind of working behind the scenes in healthcare. And yeah, so that is me. Let's go to Lois.
Okay, I've been in healthcare for 36 years as a registered nurse. I was an infection control practitioner for 17 of them. I've also been a psychiatric nurse, and since I retired, I've been a patient family advisor for UW Hospital for I don't know how many years. And then we had the COVID, and all of us were shut down. And Rosie and I have been on PCORI's, reducing hospital-acquired infections for how many years? 6, 7? So anyway.
Since 2016, Lois. Oh.
Is that what it is?
Yeah.
I just feel we've been doing it forever. And right now I have a husband in hospice, so I take care of him. And life is good. So that's me.
What did you want to be as a child, Lois?
A nurse, because I always wanted to help people. Was I nuts or what? I loved it. It was a wonderful profession.
Well, thank you for the work you did as a nurse.
Thank you.
And thank you for joining us.
Good.
Bill.
Well, hello there. I'm Bill Adams, and I live in West Central Minnesota. Let's see. What I wanted to be when I grew up. Well, actually, as a kid, I thought I would become a high school English teacher. That's what I left for college and thought I would do. And then I took an education class, and I wasn't mature enough at the time to take education classes. So I never became a teacher. So
That's funny. Yeah, it's crazy how much it can change in college. For sure. Thank you, Bill. Oh, Bobby is driving, so she can't talk. Thank you for not talking and driving. From Pittsburgh, and wanted to be a consumer complaint resolver. Majored in family consumer science in college. Awesome. Thank you for joining us, Bobby. Libby.
Hey, everybody. Good morning and happy Friday. Hope you all have a warm cup of coffee. Well, it's early here, so I have my warm cup of coffee. I'm Libby Hoy. I'm the founder and CEO of PFCC Partners, and we are a patient and family-powered organization based on my family's lived experience navigating the health system with 3 sons growing up with mitochondrial dysfunction. So okay, let me just give you some context of what I wanted to be when I grew up. I grew up with 6 brothers and then had 3 sons. So when I grew up, I wanted to be an NFL referee.
Awesome.
I
Now you
watched
can
a
do it.
lot of football games.
You probably still want to be in the NFL room for
Yeah,
I wouldn't mind. I think I could be pretty good at it, actually.
I think, yeah, I was gonna say, I think you'd be pretty good at it.
yes.
That's awesome. Thank you, Livy. And Rosie?
I'm Rosie Bartell, I come from the state of Wisconsin, a little bitty town called Chilton. And when I grew up, I wanted to be a teacher, and I did do that. I was a teacher, principal, and a director of education for a large diocese here in Wisconsin. But I thought the only way you could do that was by being a nun. So I started out my life in education in a convent because I grew up with nuns as teachers. So most people don't realize that at one point in my life, I was a nun. Not a good nun always, but I was a nun.
Gee, that surprises me, Rosie. That really shocks me.
Like that, not a good nun, but a nun. That's funny, Rosie. Well,
Well, I wasn't a
you.
rule keeper.
I went to Catholic school. I know what you were, and Livy too. Yes, we know where you came from.
You too.
And Marty.
Huh. Is there a theme?
What does that say about all of us? Oh, that's funny. Thank you so much, Rosie. And Marty.
I'm Marty Hatley. I live in Chicago. I'm a patient safety advocate. I wanted to be a teacher when I was a kid. I think it's because I have a great mom who was a teacher. And Libby, I had to laugh when you were talking about yourself because my mom was really a girly girl, and then she had 3 sons. And by the end of her, by the end of her sort of adult life, she was like the biggest sports fan. I mean, she went to all of our sporting events. You know, the sewing and the pottery and all the other things she did they were all in the garage. And then I tried to become a teacher actually, and I realized I didn't have the patience to deal with parents. I went into a teaching program at Evanston Township High School and was just I thought I could never deal with these parents. So I defaulted and went to law school, which was the right choice for me. Because it's a calling to be a teacher. It's maybe kind of like being a nun. You know, you really have to have that willingness to be patient with people.
Absolutely. Agreed. Well, thank you for joining us.
That's so funny, Marty. I just had it knocked out of me a little earlier.
Yeah. My mom had actually 5 sons. She lost one, but she had girls' names picked up for the first 3. And by the time of her 4th, she said, I give up. It's going to be a boy.
Oh my gosh.
Sounds like an amazing lady.
Yes.
She was.
That's where that patience came from, I bet.
Yeah. Yes. Well, the thing about her that was so interesting, we are all, I mean, the 4 of us are born in 5 years and we all look alike. But she treated us really differently because we were different. She played to our strengths. And I think that's a teacher skill. You know, we look generic on the outside, but she just, you know, here's what Marty's good at, here's what Philip's good at, here's what Peter's good at. And she played to those strengths and really encouraged us. And that's why I think teachers are so special.
Wow, that is
familiar.
I do too. They're wonderful.
My mom was a teacher too.
She also knew our weaknesses. So from the time I was like, and I'm the oldest. So from the time I was maybe 5, I'm the one who had all the responsibility, but she wouldn't let me give me any test that involved a sharp tool because she said, Marty, you don't pay attention to your surroundings. You walk through the world thinking, and you don't pay attention. And I'm worried you're going to hurt yourself. So all the shop, lawnmower, all that kind of stuff went to the next brother down. Anyway, enough. But this is a fun call. I had no idea these calls were so fun.
These are very much community building calls. So yes, we like to get to know each other.
Yes. Well, thank you so much. Let me just double check I got everybody. I think that I did. All
Marty,
right.
where did you grow up?
Oh, yes.
I grew up sort of on the edge of North Dakota and Minnesota. So Bill knows this because my lake cabin is very close to his lake cabin in Minnesota, but I was
Ah.
actually born 35 miles west in North Dakota. Actually, I was born in Minnesota because that was where the closest hospital was, but my family lived in North Dakota.
Ah,
Yeah.
Awesome. All right. Go ahead and move us forward here. We do have a skills exchange coming up. We have core competencies of effective partners. That will be October 11th and 18th. It's a 2-session series, each session an hour and a half, and it talks about we'll be talking about what you need to be an effective and impactful patient-family partner. We'll go over the 5 core competencies that you see here: teachable spirit, representative voice, solution focused, constructive collaboration, and establish partnerships. So we'll deep dive into all 5 of those core competencies. And I have the registration right here, and I will add that into the chat. And this will be going out in follow-ups and future emails as well. So if you don't get the chance to register now, you can check your email in the near future, and we'll be sending that out to everybody. I think a few of you have gone through that skills exchange, and I've of course watched it many times and learned something new every single time. So if you've done it, we welcome you back to join us again. And I'm going to pass it over to Libby for this one.
so great to have all of you on today. I appreciate you taking the time. And I know we're a little bit of a small group today, but we do have a lot of folks that listen to these afterwards. So I think it's really important to hear from our guests today on our coffee chat. But I wanted to start out by just really level setting. Patient Safety Day is Sunday, correct? Monday. Oops.
Sunday.
And so, but it's not really a day. I guess that's why I get messed up with the day every time.
It's September 17th. It's always September 17th.
Oh, it's always September 17th. Okay.
Yeah.
So there's a lot of activities going on about it, and we wanted to get involved. We have a wonderful partnership with Marty's organization, Patients for Patient Safety US. And I know he's going to share a lot of exciting opportunities for us in the near future. But I also just wanted to remind us all that patient safety is part of our work every single day. And it really is the high value partnerships and listening to the patient and the family perspective that is going to promote and enhance patient safety across the health system. We asked this community, PFAnetwork members, what priorities do they have for enhancing patient safety? Because we really feel so strongly that the person with lived experience, that voice, needs to be in this conversation at every step of the way. And so people responded, lots and lots of people responded, and this is the word cloud that was produced. And so this, in essence, is the perspectives of people with lived experience from the PFAnetwork telling the world what we really feel is important around patient safety priorities. And so I'm excited to have Rosie and Marty join us today and share a little bit more, but patient safety always at the top of our priorities throughout our partnerships. So thank you for your responses. If you responded to this, if you haven't yet, we can add that link in the chat, and look forward to hearing more from all of you. And with that, I'm super excited to have Marty Hatley. Man, it's so great that you're taking the time to join us, Marty. I know you've got a lot going on this week.
I do, but it's been really fun so far, Libby. So happy to be here. I don't really know the format. Do I just dive in? Is there anything, or do you ask me questions, or how do you want me to? How do we go here?
Feel free to just dive in and let us know your upcoming projects and
Okay.
Yeah.
So World Patient Safety Day has been around since 2019. It was established by resolution of the World Health Organization, and every year it has a theme. And this year, and that theme then becomes its focus for the next year, starting on the day. So as of September 17th, I'm really excited because this year the theme is patient and family engagement as a solution. And I think it's especially important right now because as I kind of look back at the 25 years I've been in this field, I've come to the conclusion, it's not cynical, but I think it's sobering, that the only thing that creates urgency around this issue is patient family engagement. So it seems like to me, like transparency drives change. You know, transparency actually is a motivator, or is a tool for driving change, because if you put data out there, the world has to deal with it. But it's that sense of urgency that comes from the patient stories and also our voices, wherever we can, connect and speak up and make a difference, that is the thing that keeps it prominent. And I say that because we're at a point in history where, we saw a lot of progress between the years 2011 and 2019, when there was real federal leadership and real federal investment in safety. And all that progress has been lost because the leaders let it drift. And I don't think leaders don't care, but they're bombarded with competing priorities, and they let this drift. And so patient family engagement, the need for urgency is here more than ever. The other thing that I think I take away from kind of my experience is that when we do focus, and Libby, you do this very well, but when we are the bringers together, the conveners of different people, I'm thinking of the way that you convened your son's healthcare providers on conference calls to get them to talk to one another. That was, I think, the first conversation we had. So kind of extrapolating from that, when we convene the partners that need to be all that fragmented, accountability structure, the creditors and the regulators and the licensing boards and the departments of health, it's us that can bring them together. They can't bring them together. They can't get together by themselves. They just don't do it. There's too many elbows out, too many jurisdictional barriers. And so we're the ones that have to bring them together and just say, look, you need to be rowing in the same direction. You need to be leading on this, because we have not, it's not that we haven't made progress. We did make progress and then we let it go. The one thing that came out of that, 2011 to 2019 period that really stuck, that I think we also need to remind people of, because people can learn from success, is we did eliminate early elective delivery before 38 weeks. That got embedded and that got stopped. And that was March of Dimes coming up with the research that was irrefutable, a Leapfrog group getting involved in it, using its grading system, and then the feds listening to the voices of us saying, look, this is something that we can fix, and this is something that should never happen because it's just inherently dangerous. So that stuck, but infection, pressure ulcers, falls, all that stuff just drifted, in part because of the pandemic. I think, our attention was diverted there, but it wasn't embedded. And so it was allowed to drift, and it frankly had started before the pandemic. So it's a very important year for us. And what Patients for Patient Safety is doing with Patient Family Center Care Partners and other organizations is a march in Washington. We've done this every year on World Patient Safety Day, but because of the pandemic, they were always really small marches. There were years where we were marching through empty streets, and we marched from the White House to the Capitol, and it's about a 20-minute walk down Pennsylvania Avenue. We plant flags on the lawn of the U.S. Capitol with the names of people who've been lost or harmed to unsafe medical care. And then we just have a very informal memorial service where we talk about what we're doing and talk about the people that matter to us, that we've seen impacted or in too many cases killed by unsafe care. So it's very meaningful, it's very human, it's very motivating, but it's been small. And so our goal is to grow it. This year, we have new partners. So we've gone out to HRQ every year saying, please partner with us. And they always say, we can't do it because you're going to be asking for legislative change and we can't be a part of that. But this year, Bob Valdez and Jade Perdue and a number of other people are marching as individuals. So they're doing what they can do. Academy Health is a partner this year. Patient Family Center Care Partners is a partner this year. we lost a partner or two because unfortunately September 17th this year is a high Jewish holiday, Rosh Hashanah, and organizations that really observe that important holiday just have a hard time, putting up on their website something else because it's an observant day. But they're still supporting us, and hopefully we'll avoid that trap in the future. The other thing that we have going for us this year is that Congress is in session. So we pretty quickly put together a second day of Hill visits. And we've got new ammo with the President Council of Advisors on Science and Technology, the report that was just released 2 years ago. So a fresh report, fresh data. It is federal leadership. I mean, I like many of the recommendations in that report. So we're going to do about 20 Hill visits that the Society to Improve Diagnosis and Medicine, which is a new partner this year also, is arranging for us. If you've worked with Leslie Tucker there, she's just a phenomenal person. And she stepped up and just is organizing that. So we're going to go in, we're going to leave them copies of the president's report. We're going to leave them another sheet showing the studies that show how this problem is as bad as it ever was. Not that it didn't get better, it got better, and then we let it drift, and therefore the need for their kind of leadership. And we have about 50 people registered for the march, which is our biggest number ever. I know it's still small, but I'm really encouraged by the fact that if it weren't on a holiday and the pandemic being over, we're going to continue to grow this year to year. So that's kind of where we are right now going into the day. If you like, I can also distribute our talking points for our Hill visits, because we spent pretty much time just kind of gathering data in that concise way that you have to do to kind of get your elevator speech down. So I can circulate that to you if you're interested, and it's got a lot of data that's kind of collected that's there.
Yeah, that would be great.
So,
Marty, I think that's fantastic. And if anybody has questions for Marty, one of the things that I've been really impressed with is the PCAST. And I wonder if you could talk a little bit more about what that group did and what they had the opportunity to push that sense of urgency forward with really specific I don't want to say, are they goals? I don't know. Really specific.
They're recommendations.
Recommendations. I'm going to say directives, like directing people, we need to do this now, because I really was impressed with what came out of that.
Yep. So we know President Biden understands healthcare really well, and we've just been waiting for his leadership. I mean, the reason we made that progress between 2011 and 2019 is because President Obama built a lot of resources for safety into the Affordable Care Act. I mean, many of you have probably participated in the Partnership for Patients. There was a bunch of research dollars. The whole hack list, hospital-acquired conditions, publicly reported by CMS, came out of the Affordable Care Act. And Biden was part of that. And Biden gets healthcare probably better than any other president we've had, but he's just not prioritized this. So we were really, and many people were looking at this going, why not? And it's because he's really busy, I think, juggling many, many other things. But there were a group of people that kind of found a way to get to him through this Presidential Council of Scientific of Advisors on Science and Technology. It's an incredibly prestigious group. There's many Nobel Prize winners on that group. It's not focused on safety, but they put together a safety working group to study this problem and make recommendations to the bigger group. So at one level, just educating all these other luminaries that have voices with leverage.
Actually, I was here this week for service, and you guys had to went over the entire
Bobby, you're
party and
unmuted.
with everything. It was over $1,500 because we had to have something.
Laura, can you
fixed.
manage that?
I turned the car on this morning. It says service required. So somebody forgot.
Bobby,
to do
you're not
something
muted.
to fix
Bobby,
that.
can you unmute? Can you mute?
No, I'm not sure. It's like the
Bobby,
last
can
name
you
on
mute?
the lead, and I was here on Tuesday. Okay.
I'll just talk over Bobby.
Okay, keep talking.
I'm bad.
So they came up with 4 categories of recommendations
I had my
in a
car
report
service
that
on
was
Tuesday, and it
just
was like
published
flow leak or a leak in the cooling fluid
2 weeks ago. And the first report is to put somebody in charge of patient safety. So under that recommendation, there's going to be a person appointed in the federal government whose job is to coordinate with all the federal agencies on patient safety. And, you know, if you're kind of having the same conversations I'm having, this is one of the things that I think that patients often ask me, who's in charge? Where do we go if we want to make a difference and make a complaint, or just tell people about our experience? And it's hard to know where patient safety is. They've also established something that's a variation on the aviation safety model. They're calling it a national patient safety team, but it's going to be a multidisciplinary group of people. And Sue Sheridan was on the working group, the patient safety working group. And as you know, she's a very strident, and I say strident with huge amounts of respect, advocate. And she just said, look, if this multidisciplinary group doesn't include patients, you know, we're going to have the same old, same old. And so there will be patients on the multidisciplinary group, and it's going to be a project, I think, of the Department of Health and Human Services. It will be under that umbrella. So it's distinct from the idea of a National Patient Safety Board that National Safety Board Coalition is recommending. It's sort of similar in concept, but that piece of legislation that's pending is for an independent agency. This is going to be under the Department of Health and Human Services. That's the PCAST recommendation. The second recommendation is that we do more research. So I'm not surprised to see that. The third is that we really engage patients and families in everything that we do. And again, I think this group worked for a year and a half, and I think it was a real opportunity to educate them about the fact that it is patients and families that create this sense of urgency. There are a number of people on this group that really care about health equity, and I think the discrimination and bias sort of, you know, embedded in our healthcare system. So I think the safety people and the equity people really connected to realize, yeah, we've got these entrenched problems that we really got to address together. So that was pretty exciting. I think I got one recommendation. I can't believe I'm doing that. But anyway, those are 3 of the 4. What is the 4th? Libby, do you remember?
I don't, because the one I'm so focused on, the 2 I'm so focused on, quite frankly, is the connection between equity and safety, as well as the one that I really am excited about supporting is the idea of an independent review board for safety, where patients and families can be part of that process and that reporting process, and to have, you know, can we make the same kind of progress that the airline industry made when that got implemented there? I mean, to me, that's sort of a proven method that might get us. And for any of you who are interested, I would strongly advise listening to a recording of a session Marty's group had several months back with other countries that have this sort of independent board, and it really opened my eyes to the possibilities. And so, yeah, I'm grateful, first of all, eternally grateful for your leadership, Sue's leadership, all of the leadership of all of our patient safety advocates. We work so in tandem with all of you to, you know, partner to co-create solutions. But yeah, just big kudos to you and your group. You've had this vision for a long time, and you are making a difference, and I'm grateful to have you here with us today.
Thank you, Libby. The 4th recommendation, I just looked it up, and it's to drive the further attention to evidence-based care. So just, you know, we see so much variation, so they just want to double down on, you know, why do we have so much variation? Why do we tolerate, you know, as much variation as we do when, especially around evidence-based practices? I think I forgot that because it sounds pretty same old, whereas the other ones sound much more dynamic.
I'm going to agree with you on that one.
Yeah.
Any questions for Marty?
If any of you know people in Washington that want to have a nice Sunday afternoon, tell them about our march. I mean, we're leaving at 11 a.m. from Freedom Plaza, which is right by the White House. It's the corner of 14th and Pennsylvania. And, you know, feel free to get the word out. I've got repairman at my front door. I'll be stepping away for just a second.
That sounds like a great time to segue, Laura.
Yes, perfect timing. Well, thank you so much, Marty. And if anybody comes up with any questions for him, you can add them in the chat or let us know and we will forward those questions over. But I am going to go ahead and pass it over. Oh, that was a fancy transition. Pass it over to Rosie, who's going to talk to us about sepsis and septic shock and tie it all into patient safety. So Rosie, go ahead and take it away. Let me know when to switch slides here.
You can switch slides right away. You probably can go to, and the second one just is, I can't, and then you can go to the next one. You can go to the next slide. I'm going to share a little bit of my sepsis story because if you read my biography, my bio, or you'll always say, what does she mean about she's had at least 14 episodes of sepsis? And I believe it's because I had episodes of sepsis that they didn't call sepsis. And, because they didn't tell me it was sepsis. And I even believe the first day that the doctor stood at my bedside and said, you have a 30% chance of surviving this. And I couldn't speak. I believe that was because I was partly in sepsis and in septic shock, because I remember not being able to focus. I remember having all those things that later I learned were sepsis, like, I couldn't get words out straight. My speech was slurred. I was shivering. I was so cold and I couldn't get warm. I was out of breath, and yet I was in a bed covered to my neck with sheets and blankets. And I usually don't ever use a blanket in the hospital. And I was feeling like I was going to die. And yet this man was telling me I was going to die. And I'm thinking, but no, I'm not going to die because I'm a survivor. And, and all of those things were happening to me. And yet they didn't call it sepsis. At that point, he was telling me I have this serious infection. And as in the last couple of months and in the last year, as people kept talking about MRSA and the fact that, because of COVID and alongside of COVID, the healthcare acquired infections have increased. The one of increasing the most is MRSA. I kept saying the next thing that they're going to talk about increasing is sepsis and septic shock. And wouldn't you know, that's the next thing that came out, because, infections very quickly lead to sepsis, especially healthcare acquired infections. And, I love what Marty has to say, and the fact that they're doing this march. The first time that I ever heard about Marty was the fact that someone sent me a picture of my name in 2019 on the White House lawn, and Marty had placed it. And I didn't even know who Marty was, but Marty had written my name and placed it on the White House lawn. And so that was the first time I heard about Marty. And I thought, this is a person who is like-minded to me. He has the same passion I have about making sure that patients are safe when they go to the hospital. So, sepsis is a life-threatening infection that really attacks your own body, your own tissues. And that means that it might attack your kidneys, it might attack your bladder, it might be attacking your heart. It might be, I can tell you that, I have decreased kidney functions because of sepsis. I have a pacemaker, and I have dealt with AFib for multiple years, and then now I have a pacemaker because it paces my heart 100% of the time because of sepsis. I have, if you ever, and most of you have seen me without makeup on these meetings, but I have black spots on my face, on my hands, on my feet, my leg, my foot, my leg, because it's part of the sepsis. It's part of the discoloration that came from sepsis. And, usually it goes away, but because I've been in septic shock so often, it's stayed. And it's almost like, and when it gets worse, when the discoloration gets worse, I know it's a sign that things are getting worse and I can, if they draw blood and do a blood culture very quickly, I know that my body is telling me I'm going into sepsis. But basically, it's one of those things that, sepsis is the number one cause of death in hospitals. It's the number one cause of readmissions to hospitals, and it's the highest cost for healthcare. So, there's over 11 million people die a year from sepsis and septic shock. 1 out of 5 deaths in the world are due to sepsis. It might be anywhere from pneumonia to, Lois, I know you're on here, and a bladder infection that turned into sepsis. For me, it was my leg that kept putting me into sepsis and still can put me into sepsis. I mean, I could be sitting here today in this meeting, and by tonight I could be in septic shock, because that's how fast it moves. That's how fast it moves. Next slide. Infection is the microorganism. Sepsis is when your own body starts causing infection to your own tissues. And then, it's like, for some people, they have a rise in temperature, and that will tell people. And it used to be, well, if you come to the emergency room and you have a rise in temperature and you have, you might have, a few of these other symptoms, then they thought you were septic. But if you came to the emergency room and you didn't have a rise in temperature, they would send you home saying it's probably just the flu. And then they realized that not everybody has a rise in temperature. By the time I have a temperature, I'm in a coma. I don't have a temperature until I am in a coma. It's the last symptom I get, not the first symptom. But but for me, my blood pressure drops. I mean, the day that I was flighted from Chilton to Milwaukee, which is really a 2.5-hour drive. By Flight for Life, it was a half hour. When they put me on that helicopter, everyone in the emergency room did not think I was going to survive. They kept looking for my obituary because my blood pressure was 60/40. And they felt that I wouldn't survive. That night, after they took me to surgery, and the next morning when they came out to talk to David, and they told him that I was in a coma, but they didn't know if I would ever come out of the coma. And if I did, they didn't think I would have my mental capacity or that my kidneys would function, because those two things had been hit really hard during this time of being in septic shock. Now, the thing I did come out of the coma after 6 days. I did have my mental capacity. It took me a while to get it back. My kidneys did take a hit, but not enough that I have to be on dialysis. But what did happen was that's when I developed the AFib and was having tons of problems with AFib and didn't at first know what it was, didn't realize that that's what it was. And until a doctor, one day I was in the hospital for another sepsis bout, and then they said, you're in AFib. And I'm like, well, wait a minute. The only good thing I have left in my life is my heart. Now you're telling me my heart doesn't work? And they said, no, it's not your heart as much as your electrical system. And that's, AFib attacks your electrical system of your heart. And that's the part of my heart that doesn't work. It's electrical system. Next slide. There are, ways to manage sepsis, and every staff member, every patient, every volunteer can help us by, first thing on the list is hand hygiene. If Lois knows, remembers David, it was his thing that he talked about at every meeting, at every turn of the corner. Pneumonia prevention, wound care, urinary tract care, early screening, making sure you understand why broad spectrum antibiotics and fluids are important and blood cultures are important, and that every hospital has a protocol. Now, when I first had sepsis, there were no protocols because people they hadn't even asked patients what it was like for them. I was the person who kept asking infectious disease preventives and doctors, when you have a patient with sepsis, do you talk to them? Do you ask them what it's like for them? And they would look at me and say, no, I never asked them that question. And so I have interviewed more than 100 people, and their stories are all the same. They all have some of the same things, especially the fuzzy brain, the slurred speech, the shortness of breath. Those things are the same in almost every patient. And most people who are survivors, that means they've lost someone to sepsis, their patient didn't have a temperature, but that's what healthcare looked for, was the temperature. And so it was missing that. And so they sent them home and said, you're okay. And that's why I got involved in talking about sepsis, not because of my own personal sepsis, but because a mother who lost a daughter at 23 came to me and said, Rosie, I need your help. I need your help because my daughter died, because 3 times in a weekend she went to the emergency room and said, I'm really, really sick. I feel like I'm going to die. And 3 times they sent her home and said, it's just the flu. And she died at home of sepsis. And so she spurred me on to start telling my story and to tell the stories of others across the country and across the world. Next slide, please. The one thing that came of all of this, and my cardiologist a couple of weeks ago said to me, Rosie, every time a pop-up comes up on my on Epic or on my electronic health records and says, have you thought about sepsis? When he said, I'll put in a symptom that a patient has, and a pop-up will come up and says, have you thought about sepsis, or have you checked for sepsis? He said, I think of you, and I think of the fact that you were the person who started making us think about sepsis when we didn't think about sepsis. He said, as a cardiologist, I didn't think about sepsis. And so one of the things that has developed from this is called the Hour One Bundle. And the Hour One Bundle has some controversy because the Hour One Bundle literally trains emergency room nurses and other nurses inside the healthcare facilities, hospitals especially, and some ambulatory facilities, to be aware of sepsis and to be able to set into protocol this Hour One Bundle without having to call the doctor. So basically they put all these things into place and then they call the doctor. And it was a big push, but this Hour One Bundle is definitely saving people's lives, because during that first hour of you being in the emergency room or in the hospital and you develop sepsis, during that first hour, the things that are important is getting the blood cultures, getting that broad spectrum antibiotic on board, getting the fluids on board. And all of those things are so important to survival. And so even if it isn't sepsis, none of those things are going to hurt you. And yet but if it is sepsis, it's going to save your life. And some people will say, well, what about the antibiotic? Well, if you're getting an antibiotic for a couple hours till they get the blood cultures back, and then they realize it's not sepsis, and they stop the antibiotic, that's okay, because that, you've survived it if it was sepsis. And so that hour one bundle is very, very important, but yet somewhat controversial among some physicians, because it moves the power from the physician to a nurse, or nurses who are trained in understanding what sepsis looks like and making that call before they call the physician. Now, for me, I went into septic shock in my doctor's office one day, and I all of a sudden couldn't speak, because what happens is just before I go into septic shock and go unconscious, I all of a sudden can't speak. I start flaring and shivering, but I can't speak. I can see myself in the bed. I'm trying to speak, but I can't. And that happened to me in a doctor's office, in my infectious disease doctor's office one day. And he looked at David and said, "What's happening?" And David said, "She's going septic." And we were like 4 blocks from the hospital. David said, "Let me take her over to the emergency room and let's get her, the things she needs in the emergency room." And the doctor said, "Oh no, I'm calling an ambulance and I'm going to go to the emergency room with her." But afterwards he said, "I have never seen a patient at this stage." He said, "I'm the guy they call to get the orders, but I'm not the guy who sees the patient at this stage." He said, I give the orders, but I don't see patients at this stage. I see them either the next day, they're either in a coma, or because we did the right things and we got it to them fast enough, they're already on the path to getting better." So he said, this was like the most eye-opening event for him. And he did ride with me to the hospital. At least that's what I'm told. He did stay with me until I was, completely, he had, put in the orders and made sure all of them were taken. But also at that point, he created standing orders. So if I ended up in the emergency room and these things were happening to me, these were the standing orders, and they didn't have to call him. So pretty much he created that hour one bundle, and before it was even considered to be created. Next slide, please. And it's all this early intervention that happens in that hour one. They have it happens in the emergency room, in the ICUs, and with rapid response teams. It happens with the nursing staff. It's about getting those antibiotics on board, and it helps delay the shock. Many times now, if I go to the emergency room, I don't end up in shock, because they already they know this hour one bundle. Next slide, please. Early screening saves lives. 85% of septic cases that go through the emergency room, ED, are prevented because of the bundle, because of these therapeutic bundles. Think about that. Basically, you're saving 85% of the people that come in with sepsis. That used to not be like that. It used to be that maybe 30% of the people survive sepsis. That's where that number came that first day, when the doctor told me you have a 30% chance of surviving, because that was the belief that when you were this ill, that's how much survival you had. Next slide. I'm ready for, this is my contact information. This is my book that tells a little bit more about my story. But, and you can, if you email me, I can tell you how to get my book. But I'm open to questions, to hearing some of your stories, to helping you understand why this is so important. I have to tell you, I was in Copenhagen. When I was in Copenhagen, I sat down with a doctor from IHI, and he and I had breakfast one morning, and we started talking about sepsis, and I told him how much I believed in the hour one bundle. And he said, well, you know, it's very controversial, Rosie. And I'm like, well, yeah, I know it's very controversial with you guys. And he looked at me and he said, what do you mean? And I said, because you don't like the giving up the power. But I said, as a patient who's experienced sepsis multiple times, I know what it looks like. And most nurses know what it looks like. The people who sometimes don't know what it looks like are the people who give the order. And in the past, you gave orders to when they suspected sepsis, but many times you might have given orders saying, I don't think it's sepsis, and let's go home. And so I said, you know, and we had a long conversation, and we've had several conversations since then. And I think he is now a big supporter of the Hour One bundle. But, you know, it is one of those things that, you know, we work in our silos, we live in our silos, and sometimes we have to get out of our silos and share the wealth. You know, last year I was doing a presentation for Superior Health, which is the hospital association for Minnesota, Wisconsin, and Michigan. And a nurse said to me, first of all, you can, if somebody comes in with chest pains, we treat them for cardiac, even if it ends up being anxiety. But she said, if somebody comes in with things that we think is sepsis, it's almost like if we say sepsis, it's like a dirty word, and we don't treat them for sepsis. And so, you know, it's moved a long way, even in 1 year, to more people understanding the Hour One bundle. But it is still a struggle to make sure that we save lives. And that's, you know, that Hour One bundle is going to save lives. And I believe it with all my heart. I believe I'm here because I had an Hour One bundle before there were any bundles. Any questions, any thoughts, any input? I know last year when I talked about sepsis, I had lots of people share stories, and I've taken those stories with me across the world in the last year, because every time I tell my story and share stories, people listen. People realize that it's not just my story, but it's lots of people's stories who are living this or who have lost somebody to this.
Absolutely. Thank you for sharing again, Rosie. It's always so powerful when we hear your story, and I always feel so inspired. So thank you for sharing, and thank you for sharing for those who can't as well. Like you said, sharing that story saves lives, and again, you're helping so many out there. So thank you.
You know, the sad thing is over 40% of those deaths are children under the age of 5.
Mm.
Wow.
And I've heard a lot of parents, you know, come to me and say, you know, my child didn't have temperature. They were a healthy child. And so nobody thought it was sepsis. And then after they die, then they realize it was sepsis. Also, you know, many times cancer patients, other types of healthcare situations, you know, people with open heart surgeries and things, they develop sepsis, and they die from the sepsis. They don't die from the disease that they could have survived, but they die from the sepsis.
Mm-hmm.
And Rosie, I think one of the powerful parts of you sharing your story is that because you have talked about this and had those conversations and spoken with over 100 other people that have experienced sepsis, to elevate the idea that patients know when something's going on, and you're really making a difference in opening the space for clinicians to hear that message differently from their patients. And that's the power of being engaged in this work, and being a patient family partner is you're such a great example of using your lived experience, as horrific as your journey has been, to inform the health system about where we need to go and to start to make those changes and shift not only attitudes. Sometimes I'll admit, sometimes I hear, a patient story and I think, there's so much more power behind that than simply telling your story when it influences and makes changes in people's hearts. Yes, everybody's going to be changed in their heart by hearing Rosie speak, 100%. But even more valuable in my mind is the lasting impact that you have, Rosie, with your story, because you're driving change. You're saying, wait a minute, patients know when things are going wrong, and this Hour One bundle is something that's in the healthcare space that our healthcare partners can access and change outcomes. And so, yeah, for me, I so appreciate patient stories. We listen to hundreds every week, and they're all terribly, terribly important. But again, the example that you set of using your story to create change is really what impacts me. So
Well,
thank you.
and even my little book, my 115 pages, that was my message, that, if my story doesn't create change, I always say, if I can just change one person's thinking when I talk and when I share my story, if I can get to one person to say, wait a minute, I need to do something differently today because of this, then I've made a difference. I don't look at my story as a sad story. I don't want anybody, I don't want anybody to feel sad because of my story. I want people to look at my story and say, here's this woman who's telling her story because she wants others to tell their story, and then she's going to take my story with her. And I think of some of the people that Laura and I connected with after last year's presentation, that I still talk with and communicate with, and ever so often I'll get an email from one of them, and I think about them. And I take, when I'm telling my story, I'm thinking about them, as much as I'm thinking about my story, because their stories are the same. And that's the part that, when originally I used to go to every single presentation. When I would go to IHI or I'd go to a conference, I'd go to every presentation that was being done about sepsis. And I'd raise my hand and I'd say, and have you talked to your patients? Have you asked your patients what it's like for them? And people would, I think some of them didn't want me to ask that question, but yet eventually people started thinking about it. For, doctors and physicians and nurses started thinking about, no, we haven't asked them. We don't know. And, the book In Shock, which was written by, I can never say her name, but anyway, she was written by a doctor from Henry Ford. And when she wrote that book, she was afraid she might be fired, because she told about all these things that happened to her and all the things they ignored in the emergency room because they didn't think she was in septic shock, and she wasn't. And when I read her book, and I remember CMS telling me I couldn't say I had out of body experiences. And then I went to a conference and she stood in front of the whole world and said, I had an out of body experience. And I remember people in the group who knew that I had been told by CMS I couldn't say that because it was too religious. And everybody in the group were looking at me saying, Rosie, she can say it on stage here, but you couldn't say it on a webinar last week, because they thought it was religious. And it's not religious. It's what people feel. It's how people feel. People who have survived it will tell you that it's so, you feel like you are passing between the two realms of the world. You are on your way. You feel like you're dying. That's the way I feel when I'm in sepsis.
Rosie, I have a friend who just almost died from internal bleeding that they took a long time to diagnose. It was after the evacuation of a fetus that had died in utero, and they nicked an artery. And she said the same thing. She saw the white light. She felt like she was hovering over herself, like she was outside of herself. She could repeat what the doctors and nurses were saying, things like, I'm not sure we can get her back. I mean, really chilling stuff. And she felt like she was watching the whole thing. So I think it's real. I don't think it's religious, overly religious. I think it's
Well,
real.
no, me either. And I'm not sure today that people at CMS would say that, but
Yeah.
back in, in 2012 or 13, that's what they were saying. You can't say that. It's too religious. But it's been one of those things that it's been a tough road sometimes because, and I think that the nurse that last year said to me, it's almost like a dirty word, like they have to now take responsibility for some things because many times it is related to a patient safety situation. It is related to something that's happening inside of healthcare, and so they have to take some responsibility. But yet, for me, it wasn't take responsibility, just take care of me. Just save my life. And that's, I think, how every patient feels. We'll talk about the responsibility later. I remember being taken to surgery one night in the middle of the night because I was started to hemorrhage. Because what my MRSA does is eats through arteries, and then I started going into septic shock. So I was being taken into surgery, and my my doctor said to me, well, Rosie, what exactly happened tonight? And I'm like, he told David, and he said, your wife called me honey tonight. And because he said, I said to him, we'll talk about that tomorrow, honey. Today, just take care of me. and I, it's not a term I used a whole lot, but I guess in that moment of going into shock, and that's what I remember saying to him, I'm having an out of body experience.
Yeah.
I can feel myself drifting away, and take care of me, save my life now. I'll explain this tomorrow what happened.
Oh. Thank you again.
That's one of the crazy things about my MRSA. It eats through arteries, and it's one of those that they've never seen happen before. But it's not always the surgical site, but it's more next to a surgical site that it just literally. And so I started hemorrhaging, and that creates me going into shock much faster than other people.
Thank you, Rosie, so much for sharing your story. And I know if others would like to hear more, you're always open and willing to speak and share. And I just am going to jump in as we close out. We're about 5 minutes over time, and I appreciate you guys hanging in. Patient safety is a team sport, and you are all members. We are all members, and we need to be active in this space. So we'll continue to stay close to our partners at Patients for Patient Safety US and support where we can as a community. So be well, be safe, and good luck with the march this weekend.
Yes.
Bye. Thank you, everybody.
Marty, I don't know if you heard me tell the
you.
story about the first time I ever heard your name.